Well, good evening, everybody. This is Justin with Iowa Western. Thanks for joining us again. Everybody can hear us. If you've got your webcams, please make sure you get those turned on. Tonight, we're going to have Grant Anderson with us. He's going to go over capnography. Grant's a paramedic from Cass County, Nebraska. We're going to let him do a little more background about himself there. They've got a unique system over there. Make sure you do have the webcams on, and like I say, make sure somebody is probably close to the computer that can mute and unmute yourselves. We're going to have a little bit of interaction tonight. So I hope you enjoy this. I'm going to turn this over to Grant and let him do a little background. Grant?
Thanks, Justin. Can you hear me okay?
We can hear you great.
Awesome. Well, first of all, I want to thank Iowa Western for having me tonight. Welcome, everybody. Like he said, my name is Grant Anderson. I'm a paramedic with Cass County Emergency Management in Cass County, Nebraska. I operate there as the EMS supervisor, and it is a fairly unique system I work for. Give a little background on the agency I work for. We are a non-transport advanced life support service, and we operate out of kind of a fly car method. The county about 2 years ago looked at our county as a whole and realized that we had some shortages, one of which is we don't have a hospital. The second one is we don't have the availability of immediate advanced care, and the other one is we're having an extreme shortage of volunteers. After 2 years of studies and discussions, we decided that we would go with a ALS service based out of the county that doesn't offer transportabilities. Our role, we serve a couple of different roles, one of which is we provide early advanced care to our patients that need it. The second is we provide just yearly staffing for our volunteers. Each one of our volunteer EMS agencies in the county all have their issues and their shortages. So not only do we provide the advanced care, but even if it's not an advanced call, we give them the manpower support. In addition to that, we help supplement with some training and work with them. It was a very flight-heavy county prior to our service, and the nice thing about it is we're able to get the patients what they need in an early manner and hopefully save some costs on the flight side. So it's a new program. We're about a year into it, and it's been nothing but a huge success ever since. So some more background about myself. I also work as a volunteer paramedic with an EMS agency here in Nebraska. It's a 100% volunteer advanced life support unit. And I'm also an adjunct instructor with Southeast Community College. So once again, welcome and thanks for having me. Just for this portion of the presentation, there will be a little bit of interaction. I like to ask a few questions to kind of segue into my topics. So it won't be a ton, but it'll be some simple questions. As I go through the presentation, I'm going to go ahead and just shut my webcam off. That way you're not, looking at me picking my nose or something. So I'm going to shut mine off, and we're going to go ahead and move forward. So like you see in the topic tonight, the topic I want to cover is capnography. This is a topic that's very important to me. I think it serves as a very important use in emergency medical services. In the state of Nebraska, we allow our BLS providers to use a form of capnography in the care they provide. I got a few different goals with this presentation. One is to kind of appeal to our advanced providers. It'll be kind of a refresher for them. Our advanced providers might actually learn a thing or two tonight as well. But the most important goal is I like to transition this into something that's understandable for our BLS providers. This is becoming one of those skills that our BLS providers are starting to be able to perform across the nation. And you can definitely see this coming down the pipe in the next 5 years as something that our BLS providers, our EMTs, and even first responders can utilize when taking care of patients. My hope tonight is to engage all of our providers, BLS and ALS, in this ever-popular skill of entitled capnography. And like all things in EMS, we're going to start things off with a little bit of anatomy and physiology, which I know everybody loves, but we have to do it because it's important that we don't just know the skill, that we understand why we're doing it. So what are we going to cover tonight? Well, we're going to cover a little bit of anatomy and physiology of the airway and understanding, the role of the airway. We're going to talk about what capnography is and what we can use it for. We're going to talk about reasons for abnormal readings on the capnography, and then at the end, I'm going to kind of wrap it all together and talk about the true clinical applications we can use it in. So we've all heard the same mantra in EMS. Air goes in and out, blood goes round and round. Any deviation of that is a problem. You know, everybody's heard it from one point or another. And using this, I'm going to try to break this down a little bit simpler because this is a true statement. And what we're going to do is we're going to reference this statement when we talk about the physiology of ventilation and perfusion. So, oops, excuse me there. So, the circle of life. When we talk about the circle of life, we talk about ventilation and the active perfusion. Okay, we all know oxygen plays a very important role in our body's sustainability, but what we're going to talk about tonight is the important role that carbon dioxide plays, or CO2, as we abbreviate it. We're going to take you back to your EMT and paramedic class a little bit and talk about the physiology of how the body utilizes oxygen and the blood flow through the body and the exhalation of the waste. So this is what we talk about when we have the circle of life. We start with our lungs, right? We all know what the lungs do. We take in that oxygen, bring it on down, diffuse it over into the bloodstream, out to the cells, turn into metabolism, and then we create a waste product. Okay, so the first thing I want to talk about is the lungs. As we inhale oxygen, the air enters our lungs and is diffused into the bloodstream at the alveoli across the membrane. Okay, so pretty simple stuff. Breathe in the oxygen. Oxygen finds its way down to the alveoli, which is those grape-like sacs that sit in the lower part of our lungs. And with those alveoli, there's a membrane, the capillary alveolar membrane, that allows that diffusion or that transition from the oxygen gas to oxygen in the bloodstream. As it crosses that membrane, yeah.
Can you back off on the mic just a touch? I think a couple people are having problems understanding.
Sure, not a problem. I got a new headset here, and it's kind of up against my neck. Let me pull it away. How's that?
We'll keep going and see how we do here.
Okay, sounds good. So, talking about the oxygen. Oxygen then transitions from the lungs to the gas, across that membrane into the bloodstream. It attaches itself to hemoglobin. Okay, I like to refer to that as onloading. Onloads itself to the hemoglobin. As it carries itself through the bloodstream, it reaches those tissues and cells that need the oxygen. Okay, the oxygen is carried onto the red blood cells, goes to those cells, and across another capillary membrane, it finds itself into the tissues and the organs that need the perfusing. As it diffuses onto those cells, it offloads. We have a positive product from that and a negative product from that. Okay, we refer to that as the metabolism portion of this stage. Okay, we're going to learn the importance of end-tidal CO2 and the role CO2 plays because we can measure more than just the oxygen. Metabolism is an important part. So, oxygen is used up within those cells. We get a positive product from that, which is energy, or ATP. But with all good things, there is some waste and some bad. Our negative product is carbon dioxide. That CO2 is then diffused back into the bloodstream. And just like the oxygen, how it attaches itself to the hemoglobin, that CO2 is carried back as a bicarbonate ion. So the bicarbonate ion part, not as important, but it's important to know that it attaches itself, carries itself back to the bloodstream, and on its way back to the lungs. So once it reaches the lungs, it's exhaled as a waste. That waste is what we're going to measure. Okay, that waste is just as important as the positive product of oxygen, how it transitions through the system. Okay, starts in the lungs, inhale that oxygen, diffuse across that capillary alveolar membrane. It attaches to the hemoglobin, taken to all the cells. Once it is at those cells and tissues, it offloads into the cell where we get the positive product of energy and the negative product of CO2. That CO2 is then diffused right back into the bloodstream, carried back to the lungs, transitioned out, and exhaled as CO2. So we have the air, we have the blood. Air goes in and out, blood goes round and round. Any deviation of that is a problem. How am I doing on sound now? A little better? I'll take that as a yes. So, transitioning into a little bit of anatomy. We're not going to spend a ton of time on the individual anatomical structures of the airway, but we're going to talk about what's important that it's involved with what we're trying to measure. Okay, we have the role of the upper airway. Talking about the anatomy of the upper airway is going to help us understand the importance of end-tidal CO2 and the types of patients we will be taking care of. Starting with the upper airway, its role is pretty simple. Warms, filters, and humidifies the air that we breathe in. Within that upper airway, we have various structures that cause resistance to airflow on exhalation that offers a positive end expiratory pressure, also known as PEEP. This PEEP helps prevent alveoli from collapsing. Okay, we talk about PEEP when we use CPAP and when we're using BVMs, the important role it plays to keep those alveoli open. It is an important role considering the alveoli is the only place in the body that you can exchange into the bloodstream. So PEEP is a fairly important thing that we need to have.
Hey, Grant, we're getting some feedback from your mic.
Okay, let me transition my speaker here.
Those new technology things are so much fun, aren't they?
I know. How about now?
Sounds good, I think.
Okay, I'm just going to hold it in my hand. So
Okay.
if you get any guff, just go ahead and send me a chat there, and but hopefully this will work out for us. So,
okay.
While stopping there, I do have a question for everybody. We're talking about the important role of PEEP. Okay, I like to always take a little sidetrack because it's a very important part of emergency care. So I do have a question. Anybody can go ahead and pipe in and respond here. The importance of PEEP and the important role of the alveoli. What happens to PEEP when a patient is intubated? Can have anybody answer in?
What happens to PEEP?
Maybe clarify what exactly PEEP is.
Okay, so the PEEP end expiratory pressure. Okay, so as we breathe in and breathe out, that PEEP is what keeps our alveoli open. If we don't have PEEP, the alveoli collapse, which then takes more work to open those alveoli back up, which then impedes the oxygen exchange. Okay, are we using CPAP in the state of Iowa?
Resistance to the air leaving.
Yes, we are.
So is PEEP going to move down because there's not as much resistance to air exiting the lungs? Yes. Yeah, right. When you're intubated.
I didn't catch that.
Is PEEP going to decrease because there's less resistance to air leaving the airway when you're intubated?
Good. That's exactly right. So virtually your PEEP will go to zero. Okay? And that's exactly the answer I was looking for. So if we have an intubated patient, the PEEP then decreases to zero because the body doesn't have that ability to control its own PEEP. Does that make sense? So in transition to that, everybody has a BVM in their ambulance. Does anybody use PEEP valves on those BVMs?
This is where you guys chime in and talk.
Sure. Out there, we do.
You do there? Where are you calling from?
Got Ringo County, Not air.
Good. Good. For those of you, I guess I don't really have a feel for the room as far as how many advanced services and basic and non-advanced services we have. But you want to talk a little bit about why you guys had them and how long you've had them?
I don't know for sure how long, but we're a hospital-based ambulance service, and so that's what they get for our respiratory department, and we get out of that too.
Good. Listen to those respiratory therapists; they know what they're talking about.
Yeah.
So basically, it's fairly simple, but it's also something that's extremely missed in EMS. Those PEEP valves, you know, me and all of you sitting in a room right now, you know, we carry our PEEP, the pressure in our system is 3 to 5 millimeters of mercury. Okay, so if you use your CPAP, you always measure it on your CPAP. It usually starts at 5, goes up to 7.5, goes up to 10. You know, we're at 3 to 5 sitting here. If I intubate anybody in this room or in your rooms, what happens is that PEEP drops to 0, and those alveoli then just collapse. So the importance of PEEP valves and BVMs, it pretty much just kind of describes itself. Or why would we eliminate what the body needs naturally? So good. I'm glad to hear somebody carries them. So I kind of took us off track, but it's a little bit important. It has to do with ventilation. So it's something to consider if you're not carrying them, is to maybe invest in some PEEP valves. They're about $350 a piece, and that's what they look like. They just go on the exhalation port of your BVM. Our service that we utilize them with, they're preloaded. Buy one, load it on your BVM, put it back in the bag. So in review, their upper airway, warm, humidify, filter the air, and provide that PEEP. That's the important role that we want to talk about tonight with the upper airway. So with the lower airway does a ton of things. Okay, we can talk a long time about the roles of the lower airway and the anatomy and physiology, but there's a couple of different things we want to talk about that pertains to end-tidal CO2. Okay, end-tidal CO2, capnography, capnometry, they all kind of go hand in hand and talking about the same thing. When we talk about the lower airway, the most important thing we have down there is the alveoli. Okay, the alveoli is where that exchange happens of the oxygen from the lungs into the bloodstream. Okay, the thing we're most concerned with is dead space. Okay, if you haven't heard about dead space, tonight you're going to learn about it, and it's extremely important. We have two types of dead space. Okay, we have anatomical dead space and alveolar dead space. Okay, the anatomical dead space, something we can't really control. It occurs from the nose down to the bronchioles. Okay, so that whole part of the upper airway down into the bronchioles, this air is not available for gas exchange. We call it anatomical because there's not any alveoli there until you reach the end of the airway. Not much we can do about that. Okay, the one that we're concerned most about is the alveolar dead space. Okay, the alveolar dead space can occur because of 3 different reasons. Okay, basically what that means is the alveoli are not able to function because of that dead space. That becomes air that is not available for exchange. So that air is not available for exchange across that membrane. One of the first reasons we have for alveolar dead space is we have air going in and out. Okay, we're breathing, adequately ventilating, but we have an issue of no blood flow. Okay, we talk about the circulation throughout the body. Blood and air have to go hand in hand. Okay, so if we have we have air going in and out, but we don't have any blood flow. Can somebody tell me an example of a patient that this might be?
Cardiac arrest.
Good. Good. It's a perfect one. So hypotension or extremely severe hypotension in the case of a cardiac arrest. Any others?
Pulmonary embolism.
Perfect. Pulmonary embolism is a perfect one. And then the other one is simply mostly any form of shock. Okay, anytime you have shock, hypovolemic, septic, anaphylactic, they all kind of do the same thing. It impedes the blood flow. Okay. The second reason we have blood flow but no air movement. Okay. This is basically respiratory arrest. This can occur. It doesn't happen as often, but tension pneumo, where you still are perfusing with the heart, but you don't have the ability to move any air. The third reason is you have airflow and you have blood flow, the surface area is compromised. Can somebody give me an example of a patient that might be?
COPD.
Good. Anything else? What do our CHF patients have most of the time?
You might have to just call on them, Grant.
What was already said?
COPD was already said. And I gave a hint. What do our CHF patients usually have?
Fluid in the lungs.
Good, good. So pulmonary edema, any type of fluid buildup in the lungs. Okay, that's one of the biggest causes of surface area compromise with the alveoli. Okay, the other one is pulmonary effusion, which is not as common, or just simply swollen membranes within the alveoli and between the alveoli. So pulmonary edema is going to be your biggest contributor to having good ventilation, good blood flow, but we have compromised surface area within the alveoli. So good. So the real question is, why do we breathe? Okay, what's our stimulus to breathe? Somebody answer that. Hopefully it's an easy one. What is our stimulus to breathe? What indicates our rate to breathe and our
CO2 level in the blood.
Good, good. So, not oxygen, but CO2. We get a lot of providers out there that still think that our breathing is based off of our oxygen levels, and that's not the case. We do have that population out there that have a pathology that allows them to breathe on what we call hypoxic drive. But with our normal people, I want to call them, we have chemoreceptors in our brain that sense the levels of CO2 and then report that to the medulla in the brain. Okay, that's our control center for our breathing. It then triggers our ventilatory effort. So as a result, eliminating the CO2, and they get oxygen in return. Like I said, we do have that small population that breathe off of a hypoxic drive. Okay, that's their stimulus to breathe is the level of oxygen in their blood. We're told to watch out for giving these patients oxygen, but what we're talking about is not depressing their stimulus to breathe. Okay, that's what we're talking about when we talk about hypoxic drive patients, and we need to be oh so careful on whether we give them oxygen or not. Well, the truth of the matter is, the length of the time we spend with these patients, it will not eliminate that stimulus. Okay, so our goal is to give a patient what they need within the best of our ability. Okay. So we breathe to eliminate CO2. Okay, that's what we do. We talk about the receptor levels in the brain, senses the CO2 levels, will increase or decrease respiratory effort based on those levels. Okay, and what that does is we get rate, we get depth, everything else is all based off that CO2 level. So the next question I want to ask, how do we measure adequate breathing? Okay. If I ask you to look at the person sitting next to you and assess their breathing, how do you know that their breathing is adequate? Somebody chime in.
Respiration per minute.
Okay. What else are we, what else are we assessing?
Chest rise and fall.
Good. Chest rise and fall. So our goal in measuring adequate breathing is looking at their rate, so how many breaths a minute, and we're also looking at chest rise and fall. Okay. That's what we teach. I'm going to show you a few fun facts here that might contradict that answer. Okay. Number one, we have a flail chest or an open chest. Okay. With those patients, the bellows of the chest are not intact, so when that chest expands, the flail segment or the hole in the chest will negate the pressure change. Okay. So when we have these patients, they're going to have good rise and fall of their chest, but they're not going to have any air movement. Okay. That's why we're taught to seal an open chest wound and to secure a flail chest. So that's kind of a prediction to our chest rise and fall on our rate, because these patients aren't ventilating at all, but their chest is rising. Number two, if you assess pretty much everybody that's listening to this presentation, you would have a hard time seeing if they're breathing adequately or not, because you won't see chest rise. Okay? Normal tidal volume for somebody at rest would require a 2 millimeter difference in the pressure. What that means is you only get about a 2 centimeter excursion or a rise of the chest wall. So if we have a patient that we assess, see that their chest is rising, are they breathing adequately or are they not breathing adequately? Are we going to bag these patients because we can't see their chest rise? I would hope the answer is no.
Okay. There's some feedback coming back. Would you all make sure that your mics are muted? I'm not sure who's not muted. I think that way Grant can hear a little better too. Sorry, Grant.
All right. So the reason I brought up these two kind of special, I'm getting a lot of feedback there.
Yeah.
So the reason I brought up these two special populations is because a lot of times we can't always base off of what we're taught. We can't base our assessment off of solely one thing, okay? But the one thing that I'm going to show you tonight is a tool we can use to adequately assess ventilation. Whether you think they're breathing adequately or not, this tool that we can use is going to assess their breathing. So enough with the physiology and enough of the anatomy. The real question is, why are we here? Well, it's capnography, okay? We're going to talk about what it is, when we can use it, why we use it, but that's what it's all about. It gives us the ability to measure the patient's ventilatory status without just looking at their chest and trying to make a determination. So, what is capnography? Okay, capnography measures the exhaled carbon dioxide at the end of each expiration. Okay, we talked about the CO2, how it comes back as a waste product. Used to be solely used for advanced airway placement in EMS. It's still the gold standard for advanced airway placement. We still use it every day on intubations and supraglottic airways like our Kings and our Combis and our LMAs. But we're starting to see it kind of turn the corner, and we're starting to see it used for a lot more in EMS, especially in non-invasive techniques, such as just measuring off of a nasal canal of a patient that's spontaneously breathing. And we use it with many different populations, not just respiratory emergencies. Okay. The important thing about capnography that we need to understand is it's a real-time assessment. Okay, it's live. As a patient changes, that capnography is going to change with them within seconds. So there's a little bit of technology involved with capnography, and we want to understand what the technology is. Okay, we have three types of capnography. One is qualitative capnometry. Qualitative capnometry is our colorimetric devices. Okay, these are those small brick-looking things we used to put on the end of ET tubes and King tubes that, as you ventilated a patient with a BVM, the color would change. You usually have a purple and a yellow, indicating that there's CO2 within the airway. The second one is quantitative capnometry. This is a skill that in the state of Nebraska, our BLS providers can utilize. What quantitative capnometry is it basically just gives you the numbers. Okay, it shows you the respiratory rate, and shows you the value of the end tidal, but it doesn't give you a waveform. Okay, the waveform is commonly used at the advanced level, and that's what we call quantitative capnography. Okay, so the thing I'm going to focus on tonight is the quantitative capnometry. What we're going to look at is just the numbers of it. We're not going to worry about waveforms or things that look kind of like EKG strips. We're not going to worry about any of that. We're going to worry about the quantitative capnometry, which is just looking at the numbers. Some people say that you can't get a good assessment without that waveform, and that's not true. It's not true at all. Quantitative capnometry has an important role, and as we're seeing in the state of Nebraska, and we'll start seeing in other states very soon, it also plays an important role at the BLS level. The technology of capnography and capnometry uses what we call infrared spectroscopy. Okay, what it does is it takes a sample of air on the exhalation, runs it through the line back to your monitor, and with an infrared light it shines through it, and it gives us our value of our end tidal CO2. The one thing that I want to differentiate the end tidal CO2 and the pulse oximetry. Okay, there's not a correlation between the two, and we need to understand the difference and not be confused. Okay, pulse oximetry measures oxygenation. Okay, the problem with that is it can be delayed. Pulse oximetry can take sometimes 3 to 5 minutes to show any changes in the patient's oxygenation status before you see it on a monitor. O2 saturation can also be kind of deceiving. We have ambient light that can be an issue, the patient's blood pressure, the patient's heart rate. You know, if you've ever had a patient with an excessively fast heart rate, that pulse oximeter might say that their heart rate's 80 and their oxygen saturation's fine, but really their heart rate's 180. It can be deceiving, and we have to understand that. The end tidal CO2 is instant compared to O2 saturation. Okay, to test this, if you have end tidal CO2 within your agency, what you can do is put yourself on both. Put yourself on end tidal capnography, and also put yourself on a pulse oximeter. Once that's done, just hold your breath. Hold your breath as long as you can. The end tidal CO2 measurements will be instant. Okay, it'll show you that you're apneic, and you may not get values until you exhale again. With pulse oximetry, you might be sitting there 3 to 5 minutes before your O2 saturation drops. With end tidal CO2, we have to remember one thing, okay? It measures more than the SpO2 or the pulse oximetry. End tidal CO2 measures the ventilation, it measures our perfusion, and it measures our metabolism, okay? Because if we don't have a good product of oxygen, we won't have a good product of waste, okay? It measures our respiratory rate, it measures how much waste we're exhaling from the system. If we don't have good perfusion, we're not going to have good waste. And remember that metabolism link that we had in the circle of life? Well, that's a measurement of metabolism too, because if we have an issue with our metabolism, then we'll have an issue with our end tidal CO2. So, just a little bit of a comparison here. O2 saturation, or SpO2, reflects the oxygenation only, okay? The lag in the change is kind of a big deal. Okay, it can take 3 to 5 minutes before you see a change in pulse oximetry. One thing that's important is if you're using pulse oximetry, it should be using CO2. With end tidal, it reflects ventilation, okay? Hypoventilation and apnea are detected immediately, and it should be used with oximetry. Okay? Simply put, if you have the ability, use them together. This is an example of quantitative capnometry, okay? This is what's displayed on a LifePak 15 monitor. This is the same monitors that I use. All monitors have their own displays, but the information provided will be the same, okay? Make sure you get familiar with your equipment if you are using end-tidal CO2 monitoring. But the other part of it is make sure that your settings on your equipment are meeting your needs. Okay, most of these monitors that have end-tidal CO2 monitoring have alarm systems as well. Most commonly in EMS, as you can see on this monitor, the alarms on end-tidal are set to off. Okay, I talked about it a little bit before, but the most important alarm involved with end-tidal CO2 monitoring is the alarm that has to do with respiratory rate. You know, what better comfort than having something tell you when your patient stops breathing, rather than having to continually assess them. Remember that the end-tidal CO2 measurements are instant, so that apnea alarm is going to be instant, and it's a great idea to have when that capnography is applied. With the non-invasive capnography, this is when we measure a patient that's spontaneously breathing. This is what we see. It's an oral nasal cannula. We have the nasal prongs, which is just like your nasal cannula for your oxygen. And we have a little kind of a flap that fits over the top of the lip of the patient's mouth. This allows the monitoring to measure exhalation from both the nose and the mouth. Okay, as you can see that this oral nasal cannula has oxygen tubing attached as well. If you're using non-invasive capnography within your service, it would be highly suggested that you just go ahead and get the one that has oxygen administration with it. It'll save you having to stick 2 cannulas in the patient's nose, and it'll save you some tubing costs as well. So you can either choose to administer O2 with it or not, and it's all right there. The next thing we have is the end-tidal CO2 adapter for advanced airways. These can be used with supraclonic airways, including your Kings, your Combis, and your LMAs. It also works with the ET tubes. It fits right between the BVM and the airway, and uses the same technology as the non-invasive as far as measuring end-tidal CO2. So we talked about colorimetric before, and the question I ask is, why not colorimetric? Okay, this is still being used today amongst EMS services as a detection device for advanced airways, whether it be an ET tube or a King tube or a Combi tube. But I'm not a fan. The reason I'm not a fan is they're pretty old school with the newest technology that we have. A lot of people don't realize that the paper within the colorimetric device only lasts about 15 minutes, so it's not good for continuous monitoring. It's good for placement checking at the beginning, but it's not going to help you out later when you're trying to reassess and make sure your advanced airway is in place. When it's exposed to liquids, it becomes inaccurate. Okay? And we all know that our cardiac arrest patients are always the same people that go to the ER with empty stomachs and no issues, but that's not the case. So when you expose to liquids such as vomiting or excuse me, pulmonary edema or anything else, it becomes inadequate. The only thing that it shows you is the presence of end-tidal. It doesn't give you a quantity. It doesn't give you any numbers. Okay. And a lot of times we're seeing with these devices is we can see some false negatives during cardiac arrest. So the colorimetric device says that there's no CO2 when really we have adequate placement and we have adequate CO2 return. Any questions so far? So we went through a little bit of the technology, and we talked about a little bit of anatomy and physiology and understanding how the CO2 is developed and exhaled from the body. So the real question is, what are we looking for when we hook these patients up to end-tidal monitoring? What exactly do the numbers mean? So the first thing we're going to talk about is the measurement of the end-tidal CO2. Okay, what's normal? A normal end-tidal on a patient is going to be between 35 and 45 millimeters of mercury. Okay, millimeters of mercury is the measurement we use for all end-tidal CO2 measurements, and that's going to be the number that comes across your monitor With your monitor, you have the respiratory rate, and then you have your end tidal. Your end tidal is going to be this number right here. Most of your patients are going to be right in this range of 35 to 45. Okay, this indicates adequate perfusion, good circulation, good ventilation. This is going to be kind of our baseline. We have what we call hypocapnia. The prefix of hypo is low, just like hypoperfusion and hypotension. So as you can guess, it's going to be everything less than 35 millimeters of mercury on the end tidal. And contradicting that is hypercapnia. Hyper mean high is going to be everything greater than 45 millimeters of mercury. So I'm not going to step into the clinical applications, but we're going to try to understand a little bit of why we have either hypocapnia or hypercapnia. Okay. With hypocapnia, that means our end tidal is low. Okay. So usually what that means is we're blowing off the CO2 faster than we're making it. Okay. Most commonly, it's going to have to do with any time a patient's hyperventilating. Okay. As you breathe faster, the CO2 gets released faster. Okay. As we blow that CO2 off, your end tidal decreases. But the worst thing that can be happening is we could be doing the hyperventilating for the patient. Okay. That's when end tidal becomes a great tool, whether you're managing a patient with assisted ventilation, with a mouth-to-mask BVM, or maybe you're managing a patient with an advanced airway. With capnography, it'll help kind of limit hyperventilation that we're doing as a provider. Another reason of hyperventilation is simply metabolic compensation. So this is going to be something going on within the body that causes us to hyperventilate. Most commonly, that's DKA or the diabetic ketoacidosis or traumatic brain injuries. And if we can remember from our trauma lectures, patients with traumatic brain injuries have the irregular and rapid ventilations. That's usually due to a issue with the brainstem or the medulla, which controls our breathing. Another reason for hypocapnia or low end tidal is hypoperfusion. We kind of talked about this before, but if blood doesn't get back to the lungs to exchange the oxygen and the CO2, the amount of CO2 coming out is going to be diminished. Just like as we discussed earlier, these are our shock patients, any patients with low blood pressures, pulmonary embolism, or ultimately cardiac arrest patients because they don't have any blood circulating. Another reason for low end tidal CO2 measurements is hypothermia. And most commonly when we talk about hypothermia, we know that it slows our metabolism. Everything slows down. Well, if we slow everything down, then we're not able to produce as much energy and we're not able to produce as much waste. So our end tidal values also then decrease. So reasons for hypercapnia. Okay, so this is when our end tidal levels increase greater than 45. Okay, simply put, this is CO2 retention. Okay, COPD patients tend to retain CO2. Over time, they have an increase in CO2 within their bloodstream, and it becomes slowly overlooked by the medulla. And these patients at the baseline are going to have higher end tidal values. Okay, it's not uncommon to see a COPD patient with an end tidal value of 45 to maybe even as high as 60, and that be their baseline. Okay. With hypercapnia, it's usually caused by some sort of ventilatory failure. So when we talk about hypocapnia and low end tidal, it's because we're usually breathing too fast and we're blowing it all off. With hypercapnia or high end tidal, it usually means we're probably not breathing adequately enough. So usually it's involved with slow ventilations or hypoventilation or respiratory failure, which can cause those CO2 levels to rise. That does is that creates an inability for that body to normalize the CO2, and it just continues to build up and build up until it becomes an issue, such as cardiac arrest. The important thing to remember about end-tidal CO2 is it doesn't tell you why or how. So we know that their end-tidal values are either low or high. We know that their breathing rate might be slow or fast, but we have to try to understand why. Okay, so don't get stuck up on the monitor and the readings and everything that it tells you. Try to understand why. Know that it's there, but it doesn't tell us why. So now we're going to kind of put it together and talk about some clinical applications. Okay, so this is when we're going to use it in the field and what we can do to benefit our patients while using the capnography. So with a BVM, just a quick question to everybody. Most commonly within your services, do all of your airway management skills involve one rescuer working the mask and the BVM, or do you guys have it as a policy to work with two?
To do it proper, you need two.
Good. Is that what happens, though?
All depends on the number of people on the call.
Yep, that's a good point. Very good point. Airstar says either way. Anybody else want to chime in? It should be a big focus when we're doing our training, doing our airway management training, trying to get into the process of when we have the ability, of course. Staffing always can be an issue. But when we have the ability, doing a two-person bag valve mask technique is going to be what's best. It allows one person to strictly control the positioning of the airway and the mask while the other person ventilates. With this two-person technique, we can utilize end-tidal to adequately measure our ventilation. Okay, so if we have a patient that we're assisting ventilation on, and I'm using a bag mask, and we have a good seal, and I have 0 on the end-tidal value, all that tells me is I'm not getting any air in or out of the lungs. So we're looking for that end-tidal value to exist when we're using bag valve mask technique, and it can be extremely difficult for one person to do by themselves. So if you're using end-tidal within your services, that would be another thing that I would suggest that you preload onto your BVMs is that end-tidal CO2 monitor that is the adapter for the advanced airways. That way when you go ahead and pull out your BVM, you have it right there, loaded, ready to go. Here's a good example of that, okay? One guy's managing the airway, positioning of the body, the other guy's working the ventilation. Don't have to focus on doing everything at once. His focus is airway placement and mask seal, while the other guy strictly has to worry about ventilating. So the other clinical use can be advanced airways while we're doing CPR, okay? One thing about quantitative capnometry, which is just the numbers, is it's never going to be able to tell us that we have good placement in a cardiac arrest. The only way we can tell if we have good placement in a cardiac arrest is if we have a paramedic to interpret that waveform. With the capnometry, the quantitative capnometry with the numbers, you still could get some low CO2 levels that exist within the esophagus. You can have some low CO2 levels that can present with poor perfusion states during compressions, which is typical. These patients are going to have low end-tidals the way it is. So we don't know where that low end-tidal number is coming from specifically. So unless we can have a waveform with it that the paramedics can interpret, we're not able to determine correct placement. So with low cardiac output equals low end-tidal, okay? The heart's not pumping, we're not going to have any end-tidal. It's going to be very low, okay? The one thing that we can utilize end-tidal for is to try to determine if we have a return of spontaneous circulation, okay? If we get pulses back. the one cool thing about end-tidal CO2 is if you have a patient that's pulseless in apnea for an extended period of time and you get a pulse back, that end-tidal CO2 number is going to spike, and it's going to spike probably 20 to 80 points greater than what it's at while you're doing your cardiac arrest. The other thing that end-tidal can utilize with an advanced airway is if you have an end-tidal of 0, then you're probably not in the right place. Okay, we can have low end-tidal values in the esophagus and the lung, but if it's 0, then that just means we're getting nothing, and that's not a very good sign. So I'm going to show you a little bit of graph to kind of show you this is a trending pattern of end-tidal CO2 levels in a patient with cardiac arrest. On the left side, you can see where CPR is initiated. Their end-tidal is sitting right around 10 to 13 millimeters of mercury. Indicated by right around at the 1, they deliver a shock there, continued CPR, end-tidal remained 10, continued CPR until another shock, so a secondary shock was given, end-tidal remained 10, and after a short period of CPR, about 20 seconds after that second shock, you see that end-tidal just shoot through the roof. It went from 13 to 55. You just now determine that that patient has pulses back without even checking a pulse or stopping compressions. So it's a really cool tool in CPR utilization because these patients aren't going to have end-tidal decreases like that unless they now are starting to perfuse again. Do I have any questions about end-tidal use with the advanced airway and CPR? So we can utilize end-tidal with advanced airways on patients that are still perfusing. So if we're providing airway management of a patient that's in respiratory arrest but they still have pulses, we can utilize end-tidal for that as well. With that, you're going to use your similar mindset of end-tidal with the patients that would be monitored with just the cannula. Okay, but the most important thing when providing, whether it's bag valve mask or advanced airway management, use the end-tidal to watch your rates. One of the biggest things that happen in pre-hospital care is we're not watching our respiratory rates well enough when we're using bag mask ventilation. We're also not watching the amount of air that we give. So you might think that you're doing 6 to 8 breaths a minute or once every 6 to 8 seconds or 10 to 12 breaths a minute, but in all reality you might be going way slower or way faster than that. Nice thing about end-tidal CO2, it's going to give you your exact count of your respirations a minute right there on the monitor. So, Justin, if you're okay with that, I think we can go ahead and take a quick break here. I'm a little bit ahead of schedule.
Yep, I think that probably works good if we want to take a break and come back in, what, 10, 15 minutes at the most?
Sounds good.
Hey, just a couple minutes and we'll get started up here again, guys.
All right, are we ready to move forward, Justin?
Get myself unmuted there. I think everybody's back. We can probably keep moving.
All righty. So before we kind of transition and talk into the role of capnography in our non-intubated patients, I want to do a little bit of a review. This is going to require a little bit of participation from the group. You can either use the chat portion, or if you want to chime in, you can unmute yourself when you want to answer. But I just want to talk about some of the causes of low end tidal and increased end tidal. Okay, so I just want somebody to go ahead and give me a reason why we would have a low end tidal value or hypocapnia in a patient. What are some causes of that?
We're not very interactive tonight.
No, they aren't.
I wrote it down, so we could be making them hyperventilate, or they're...
Taking notes, I love it. Okay, hyperventilate, we'll start with that one. So let's talk a little bit more about that. What are some reasons for hyperventilation?
taking in more, or...
Just think about just like a chief complaint or a population of a patient that's hyperventilating? Just think about some medical emergencies that cause that.
Anxiety.
Anxiety, correct. Anxiety is a big one. Okay, that's one of the bigger causes of hyperventilation. What else?
Scared.
Okay, kind of fit in with anxiety a little bit. Anything else? Exercise. I see exercise from Maristar. That's true. We talked about brain injury patients. Those are another population that we'll see hyperventilation from. What's the other one?
Oh, the DKA.
Good, good. Diabetic ketoacidosis is another cause for hyperventilation. So hyperventilation can happen for a number of reasons, and there's going to be some more that we talk about in a little bit here, but that's one of the biggest causes of hypocapnia. Are there any other causes of hypocapnia? Oh, we got hyperventilation. What else?
Shock.
Good, good. So talk a little bit about shock. What kind of shock?
Pretty much any kind.
Okay, good. So hypovolemia, anaphylactic, anything that decreases the perfusion or the blood pressure is going to be a direct cause to hypocapnia. Are there any other reasons for hypocapnia?
Hypothermia.
Good, hypothermia. What does that do to us?
Slows down our metabolism.
That's all right. So as the metabolism slows, so does everything else. So our output of end-tidal decreases. All right, hypercapnia. So increased end-tidal. I didn't touch a lot on the specific populations, but what happens with hypercapnia?
Over time, the CO2 increases slowly.
Good. So with our COPD patients, right, they're going to have hypercapnia. What else? Anything?
Respiratory failure.
Okay, so with respiratory failure, we talk about hypoventilation and respiratory failure. What are some medical emergencies that cause either of those?
Cardiac arrest.
Okay.
Low blood pressure.
A big loss at the casino. Love it.
What did he say? Big loss at the casino.
Maristar chimes in and says a big loss at the casino. What's a patient that we have that we might show up on that looks like they're barely breathing? They'll be pale, unresponsive. Think about more than just the natural causes. Think about other substances and exposures. You guys have any overdoses in Iowa? What kind of overdose? What kind of overdose causes hypoventilation?
Like
Opiate.
narcotics.
Opiate overdose?
Correct. Opiates and narcotics. So those are going to be your patients that are going to be hypercapnic solely because they're not breathing adequately. So as their respiratory rate decreases, their end-tidal values are going to go ahead and increase. So good. All right, so we're going to go ahead and move on here and talk about the non-intubated patients. That kind of review will segue us into the next topic. And we're going to talk about the individual populations and the individual medical emergencies that we can measure end-tidal CO2 values on. The first one I talk about is our COPD patients, okay? COPD exacerbations are very frequent. We're starting to see them more and more in EMS. And end-tidal CO2 can be an extremely helpful tool when assessing and taking care of these patients, okay? As they're having an exacerbation, the levels will increase, their end-tidal levels will increase from that baseline as a later sign, okay? But the important thing that we want to talk about is when we have these patients, COPD, CHF, asthma, everything else, with their end tidal values, they can trend awfully similar to the way patients trend that are in shock. Okay? If you have a patient with a COPD exacerbation, initially they might be breathing rapidly and compensating well for what's going on within their lungs. So they might have that hyperventilation we talked about before. Okay, so initial findings on these patients, if you catch it early, might have hyperventilation, which would cause them to be hypocapnic or have a low end tidal CO2 level. Now, one thing we want to look at in these patients with acute exacerbations is when we start seeing their end tidal when we start seeing their end tidal increase. As their end tidal increases, that's when we become more and more suspicious that what they have going on is very serious. Okay, their end tidal will initially decrease at the beginning. They'll compensate, start breathing rapidly, and then all of a sudden they're going to get things like fatigue and tired. And when a respiratory distress patient tells you that they're feeling tired, that should perk your ears right up. These patients are probably going to have increased end tidal values, sometimes greater, up to or towards 100 for their measurements. Okay, what this is going to do is it's going to greatly help your confidence in the use of CPAP with these patients. If you have a question on a patient that might need the CPAP, you can say, all right, we're going to use this in addition to our thorough respiratory assessments. We're going to go ahead and add end tidal onto the mix. And if we think that they are having acute respiratory distress and they're not oxygenating well and they're a candidate for CPAP, and then they have an end tidal of 100, then they're definitely a candidate for CPAP. Okay, so we're using end tidal as an additional tool within our arsenal of our assessment. So we don't just use it alone, we use it in conjunction with everything else. The next population is our CHF patients. Okay, CHF patients are kind of a unique population as far as when it comes to measuring end tidal CO2. Some CHF patients might have a low end tidal, and some CHF patients might have a higher end tidal. Well, this is solely because of the underlying signs and symptoms of the CHF exacerbation. Okay, low end tidal volumes can occur when we have poor cardiac output. So we talked about the perfusion before. If our pressures aren't very good, we're probably not going to have very good end tidal values as well because we're not getting good perfusion. The next one's pulmonary edema. You have a CHF exacerbation, the patient's just filling up completely in their lungs full of garbage, and we need to get that fluid out of there utilizing CPAP. Well, they're going to have a low end tidal CO2 level because that capillary alveolar membrane is just overfilled with fluid. So they're going to have low end tidal CO2 levels strictly because that diffusion or that transition of oxygen into the bloodstream and CO2 back into exhalation is not going to happen. Another reason, on the early signs of a CHF exacerbation, they might have that hyperventilation as well. Okay, they're going to compensate in the beginning, then we transition over. As they start getting fatigued, they start getting tired, we see their end tidal values increase. Okay, we'll see them shoot up through the roof and ultimately might lead to respiratory failure. Fatiguing will definitely lead to respiratory failure if we don't nip that in the bud right away. So, as you can see with these patients, not just these two, but more we're going to talk about, you might see that hyperventilation initially, which would give them a lower value, but when we start seeing those higher values, that should really increase our suspicion that something's going on and we probably need to get it fixed. Asthma patients. So, with asthma patients, also kind of a unique population. With these patients, they probably should always be assessed with end tidal CO2. Okay. These patients a lot of times might have a pulse oximetry that might appear normal, although they're experiencing some severe bronchospasm and will benefit from our albuterols and our duonebs and our epinephrine. Okay. These patients will have increased end tidal CO2 levels, and the higher the end tidal CO2 level, the greater the risk for respiratory failure. So really watch those numbers on these asthma patients, because they might show that they're oxygenating well. They might not appear well. They'll probably appear very, very sick. But if their end tidal values are through the roof and keep increasing after albuterol and epi and duonebs and everything else, you need to have a high suspicion of respiratory failure. Okay, these are the patients that we want to watch the trending on the most with their end tidal. Okay, if they keep getting worse and worse, chances are their end tidal is going to keep getting worse and worse. So as it's trending up, we need to make considerations for ALS intercepts or flight or whatever you're easily accessible to. But these patients are going to be sick, and they're going to continue to get sicker. The next one is we kind of rope multiple things into what we call hyperventilation syndrome. Okay, these patients are going to have decreased end tidal CO2 values, especially our ones that have what we call panic attacks or anxiety or psychological issues. Okay, the one thing that we can use end tidal CO2 for with these patients is to help guide us through our coaching. There's not a lot we can do for these anxiety patients. Anxiety attacks are real. They're real things, and it's our job to console them and help guide them through it. Okay, one of the best techniques we can do is help them coach their breathing, help them breathe through it, slow their breathing down, use rhythm breathing. All those things are helpful, and we can use those end tidal values to help kind of coach us. You know, if they're sitting at an end tidal CO2 of 18, which is well below our 35 and 45 range, you know, and they're breathing 45 times a minute, we probably need to help them kind of slow their breathing down, help normalize that end tidal, and chances are they're probably going to just kind of come out of it. You know, some of these patients might need some medication, but a lot of time that coaching of the breathing is very beneficial for these types of patients. Some other conditions that cause hyperventilation syndrome and low end tidal values, sepsis, which is a form of shock, pulmonary embolism, which we kind of talked about before. It's, you know, an obstructive form of shock. Diabetic ketoacidosis. These patients are very sick patients, and they're going to have hyperventilation syndrome. They need to be taken care of. And also our head injury patients, you know, TBIs, traumatic brain injuries, any sort of signs of brain bleeds or herniations, they are going to have hyperventilation syndrome as well with low end tidal CO2 levels. The next type of patient we have are our trauma patients. You know, people don't think, you know, well, there's nothing going on respiratory, so why are we going to even consider end tidal CO2 measurements on these patients? Well, the truth is, with end tidal, you know, we're measuring perfusion and ventilation and metabolism. Our assessment findings might be beneficial when including end tidal CO2. If you have findings that are consistent with hemorrhagic shock or hemorrhage, hypovolemia, slap the end tidal CO2 on, and with low perfusion equals low end tidal CO2. These patients are going to have lower end tidal values with hypovolemia and other signs of shock. The next type of patient population are overdose patients. Okay, most commonly are narcotic overdoses, but there are some other drugs out there that can cause respiratory depression, benzodiazepines and things like that. Patients with an altered mental status can be monitored for ventilatory status with end tidal CO2. Okay, this is an important tool. There's a very highly talked about topic out there right now about the ability to give Narcan to non-licensed personnel, you know, police, bystanders, you know, over-the-counter purchases. I can say that I'm a very big proponent of that as long as we teach them how to do it properly. Just because a patient's unresponsive doesn't mean they need a reversal agent, okay? We can monitor that with the end tidal CO2 values, okay? If I got a patient that's unresponsive on the floor and I take a look at their end tidal values and their SpO2, we might just want to leave them unresponsive if their end tidal CO2 is within that range of 35 to 45 and their pulse oximetry is 98%. I don't know how many have had experience with reversing a narcotic overdose, but A lot of times if you push the reversal agent, Narcan, too quick, too fast, too much, the end result for your crew is not always beneficial. Vomiting can occur, anger, physical abuse from the patient. So we can use end-tidal CO2 to really evaluate their true respiratory status and determine whether the patient needs a reversal agent or not. You know, they might be breathing adequately and they might slow their breathing, maybe a little assisted BVM ventilation, some stimulation. This is one of those tools that can really, if it develops within the scope of practice of our EMTs here in Iowa, can really be a useful skill with these narcotic overdose patients that, you know, sometimes you feel helpless when taking care of them because there's not much we can do without a reversal agent. Well, if they're breathing adequately, then we can go ahead and just support it and get them to the hospital, and technically we don't need ALS. So the biggest thing with these patients on the non-invasive capnography or non-invasive end-tidal CO2 monitoring for CHF, COPD, overdose, asthma, watch your patient and watch for trending. You know, we're not just spot checking the end-tidal. We want to make sure that we're taking a look at it and we can see the patient whether they improve or deteriorate based on their end-tidal values, because there's a direct correlation between ventilation, perfusion, and metabolism and end-tidal CO2 values. Remember that these results are instant, as opposed to our SpO2 readings. These results you're going to find right away when you attach the patient to end-tidal CO2 monitoring. To show you that, here's a little graph that kind of indicates with our COPD, CHF, asthma patients kind of the trending pattern of how their CO2, their end-tidal CO2 might go. So at the beginning of the phase, we have their normal status without their exacerbation or their emergency. As you can see, as they move along, their end-tidal will decrease into a hyperventilation state as they're compensating for that respiratory emergency. Now, if we don't reverse that respiratory emergency with medications or breathing treatments or whatever it might be, the body can only handle so much. As you see them move along that pathway of continued respiratory distress, we start seeing things like respiratory failure. That's when you start seeing the end-tidal CO2 spike. With these patients with high end-tidal CO2 values, usually going to be relatively high, we need to start having a very large suspicion that something is truly wrong and we need to get it fixed. Okay, and ultimately, as that CO2 retention occurs and that fatigue continues, their end-tidal CO2 is going to quickly drop in the form of a cardiac arrest, which you're going to then have an end-tidal value of 0. So keep an eye on all these patients, make sure we're monitoring them correctly and watching for trending patterns. Does anybody have any questions about end-tidal measurements on the non-intubated patients? Non-intubated patients is this is where I have the most fun with end-tidal CO2 monitoring. I can honestly say, in my position in Cass County, Nebraska, I do put end-tidal CO2 on almost every one of my patients for the reason that it's a very vital tool to utilize in addition to everything else in a good assessment. So talking about a little bit about the technical application of end-tidal CO2 and some special situations when it can be utilized. The first one we talk about is CPAP. And the question always arises is, how do I measure end-tidal CO2 in CPAP? Simply put, with your oral nasal cannula, you can go ahead and utilize that under your CPAP mask. You'll get a lot of grief sometimes from people that are seasoned veterans or have been in the field for a long time, or even some respiratory therapists. I argue with one every day that's my girlfriend that says I can't do this, but you have an adequate seal when you place this on the patient's face and you have end-tidal involved. Never seen any research to back up that the seal's broken. These masks provide a good enough seal that that tiny bit of tubing measuring their end-tidal value will benefit them. one of the questions people ask a lot is, well, why can't I just put the advanced airway adapter between the mask and the circuit of the CPAP? Well, there's a couple different reasons, and one is you have to be familiar with your equipment on whether you can utilize that or not. A lot of CPAP and BiPAP masks have exhalation ports within the mask, so if you're losing that exhalation within another portion of the mask, then your end tidal values won't be accurate. The other answer to that is the fitting might not work. Your end tidal CO2 adapter for advanced airway has a larger end for the BVM and a smaller opening for the advanced airway, whereas a CPAP mask, if we were to break the circuit away from the mask, they're both probably going to be the same size, so it wouldn't work without an adapter. So if you're going to utilize end tidal CO2 measurements on a patient with CPAP, and I strongly encourage it, go ahead and place them on that cannula and just secure the mask over the top of it. So the next thing we ask is, what about the peace pipe? Okay, our handheld nebulizers. You know, can we measure end tidal on a patient with that? Well, the answer is yes. Your data might be a little bit skewed. There's been some research out there that with albuterol treatment, you might have some increased end tidal CO2 values. But if you want to, this is something that I just did a week ago and took a picture of it at my office. I took the advanced airway adapter and stuck it into the T and connected the nebulizer right to it. And as they were exhaling through the mouthpiece, I was able to capture end tidal CO2 values based on them mouth breathing through the neb and exhaling through the neb. Are there any agencies out here using the rescue pod, the impedance threshold device? I don't know.
I don't know of
Yeah,
anybody.
I don't think there many people are.
Okay. Well, I'm not going to spend a lot of time explaining what an impedance threshold device is, but we utilize it for cardiac arrest patients. It has to do with anathoracic pressure, and it's really some exceptional research behind it. If you want some homework to do, go ahead and look up some data involving the rescue pod impedance threshold device. So I always include this in my presentation as well because it's commonly used in eastern Nebraska. That the end tidal CO2 measurements can be used with a rescue pod impedance threshold device, and this is the process that we go about when utilizing it. So get your advanced airway, slap the rescue pod on top of that, and stick your end tidal between the rescue pod and the BVM. So So in conclusion, with the end tidal CO2 monitoring, there's many uses for capnometry and capnography. As you can see, it benefits the use on many patients and not just only the patients in respiratory distress. The most important thing, and our paramedics, we use this mantra with cardiac cases, treat your patient, not the monitor. Don't get tied up on what their end tidal CO2 value is if they're completely asymptomatic and appearing normal. Treat them, don't just treat the number that's on the monitor. Utilize that number as an addition to your assessment skills in determining the severity of a respiratory emergency or emergency that would affect the respiratory system. Remember that this is just a good adjunct to a good assessment. Okay, we can never go away from our assessment skills such as lung sounds and our primary assessments and our secondary and our focus assessments. This is just to help kind of supplement that. And the most important thing is practice, practice, practice. If you're going to get involved with the use of capnography and capnometry, make sure you know your equipment, make sure you're comfortable in using it, and if you're going to use it, I encourage you to use it as much as possible. So this next slide I have is what I utilize for our Nebraska services that have capnometry in the system and within their protocols. The question that arises is it really a BLS skill? Well, it is. And for you Iowa EMTs out there that can't utilize this skill, I'll tell you that there's two things. There's scope of practice and there's scope of knowledge. You know what you can't do and you can do as a provider legally, but at the same time, it doesn't hurt to be informed about this type of information, because I can assure you, just like we have 12 leads being involved with BLS services, within a few years at the BLS level, you're going to be looking at the ability to read those 12 leads. You're going to be looking at the ability to utilize end-tidal CO2 as a BLS provider. The truth of the matter is, when it comes to resuscitation, our BLS providers own the resuscitation. Okay, our paramedics, they don't do anything that's proven to benefit our patients in cardiac arrest. The cardiac arrest, usually the good outcomes come from good BLS, good CPR, good basic airway management, and good defibrillation. So this skill is going to be added, mark my words, in the next few years, and I know it's already being discussed, but in my opinion, we would just be silly not to supplement our BLS providers with this type of tool within our arsenal, and I think you'll see it just like we are here in the state of Nebraska. So, does anybody have any questions for me? I'll open it up now. Show my lovely face back here on the webcam.
Do you think this is something that the Iowa legislation and the state health department will come down with for Iowa to start doing this on their BLS?
You know, I do. I can't speak a lot for the state of Iowa as far as your guys' administrative structure. You know, in the state of Nebraska, we're kind of monitored by the State Board of EMS, which writes our protocols within our rules and regulations. If you have a similar model and you have, you know, EMS providers in charge of your EMS protocols, I would say 100% yes. If you have state legislatures and state officials in charge of your protocols, then you might have a little bit more of a speed bump to overcome. So my simple answer is yes, I do see this happening in the near future.
Justin and I will both